Hello, ladies and gentlemen. Welcome to HAS 20 Virtual Summit Breakouts. During this session, you'll be able to submit questions and upvote questions from other attendees. The questions with the most votes will most likely be among the questions asked by the host to the presenter at the end of the session during the live Q&A. The bottom right tile box is where you can type in your question as well as click the thumbs up button to upvote a question. During the session on the top right tile box, you will also see a 5-question quiz based on the speaker's content. Enhance your learning by taking the quiz during the session and get points for your correct answers. All sessions will be available on demand, and if the presenter has given us permission, you will also be able to download the slides. It is now my pleasure to introduce session 31, the Analytics Emergency, Rapid Deployment of a Real-Time Analytics-Enabled Incident Command. It will be presented by Michael Hoke, Healthcare Data Scientist, Analytics, Albany Medical Center. Enjoy the session.
Welcome everyone to my session. Today I'll be walking you through how Albany Med set up real-time analytics for our incident commands during the COVID pandemic. Here's a brief agenda. I want to walk through what the state of analytics was before the pandemic started. Then I want to talk you through the different phases we have of our rapid response, work through how we brought everything together, and then summarize to get all of this information to our incident command and leadership. So let's first go over what the point of all this is and what I hope you can take away from this presentation. First, I want to really emphasize how important it is that leadership and decision makers have access to all of the information they need whenever possible, especially in a crisis. When everything is changing real time and you have this unknown virus coming in, strategy kind of goes out the window and everything becomes tactical. That requires the latest information. I also want to stress how important it is to embed analytics in all steps, not just the team, but the mindset. Next, it's important to show how some basic data collection at every point along the way can really help you answer those questions that come down the road that you weren't even expecting. Finally, I really want to make it clear how important it is to reduce all of the barriers you have to decision making. Trying to work around siloed processes, constantly changing regulations, trying to solve problems that are system and statewide, especially when you can't have more than 10 people in a room at the same time, that just isn't going to work. So what we need is quick access to information and to reduce those barriers. So I work in New York State, around 3 hours above New York City at Albany Medical Center. We're a 766-bed academic medical center that covers that whole area there to the upper right. We're the only level 1 trauma center in about 100 to 150 miles, and we take in around 15,000 transfers every year from the different facilities in that area and sometimes beyond. Our ED also sees anywhere from 200 to 240 patients every single day. So let's start off with the state of our analytics before the pandemic hit. This should look really familiar to anyone who's familiar with an enterprise data warehouse, and it's pretty straightforward. The first step is the operational source. These are the programs that run all of those frontline applications. They generate data, and they generally store them into some sort of operational database. Maybe this has some front-end reporting capabilities, maybe it doesn't, maybe it's customizable, maybe it's not. These systems usually then drop off into some sort of source database. Maybe this is an actual database, maybe this is just some set of files that you have somewhere. Usually the customization here is a little bit more apparent, but you usually have very limited ability to merge different systems together. Finally, we aggregate all of this data into our enterprise data warehouse. This is where we can do some amazing things. We have advanced analytics, we have all of these different systems working together. We can combine all of this information, but we run on about a 2-day lag. That because it generally takes around a day for it to go from the operational source to that source database, and then we pick it up the next night. This is great for those requests that we get where we need historical information, where we don't need to worry what happened the day before or even 2 days before, but during early March, this was not the case at all. So we formed our incident command on March 9th and saw our first case a couple days later. The incident command structure was fairly standard. We had representatives from all of the major groups in the hospital: nursing, HR, risk, IT, logistics. They were all getting together twice a day to meet to discuss preparation, planning, and the current state of things. This was crucial to breaking down those barriers to making decisions. Having everyone connected every day meant total transparency in our decision making. Everyone was aware of what was going on, when it was happening, and everyone could comment and react and be kept up to date. Dr. Venditti, who's our EVP, System Care Delivery, and our hospital general director, was clearly aware of this important meeting structure and cadence, but he also knew what was missing. They needed data. They needed information. That's when the analytics team was contacted. Leadership needed to be able to take our supply and match that with this incoming unknown demand. As Dr. Venditti says here, we needed this immediate access to actionable data on all of our resources, staff and patient needs. We needed to match that supply with demand. So I received a call on March 14th at around 9 a.m. I made it into incident command a couple hours later to deal with this thing that I never thought possible that was ever going to happen. My VP never thought was going to happen. There was an analytics emergency. So let's start with phase one, which is our patients. We needed basic information on our patients. We needed to know who they were, when they were coming in, where they were in the hospital, why they were coming in. Did they need testing? Did they need treatment? We needed to know how we were going to provide that treatment, and then we needed to be able to figure out how we were going to follow up with them. These are all basic questions to answer, and this is the information that our hospital during this pandemic needed real time. So this means that the regular processes we had set up just weren't going to work. We needed to cut out all of the middlemen in this scenario and get the source data as it was happening. This meant going directly to the HL7 messages that all of the different hospital systems use to communicate with one another. This means we can see things as they're happening and be able to pull that data in and react to it. Now, when I say real-time data, that's a bit of a misnomer. Everything has some sort of lag to it. Those HL7 messages that come over are fairly raw and they're not processed at all. But what we were able to do was go from that 2-day lag, which now seems like an eternity, all the way down to just 5 minutes of processing time. So we're lucky to have an amazing integration team. They had already set things up. They handle all of the communication between the different systems in the hospital. And they had already been testing a new setup for a new EHR that we were able to tap into. This was the most basic and fastest way to set things up. We set up 4 basic tables: patient, visit, orders, and results. Patient and visit contained all of the general demographic information, registration information, all of that about the patient and their visit, where they were in the hospital. Orders contained all of the lab orders that were coming out of our lab system, as well as any indications that were on the e-order or other pieces of information that would get attached to that ordering process. The final table results contained all of the results that came out of our lab system, and then any other miscellaneous bits of sort of key value information that we needed storing. Now, could this system have been better? Could we have set this up to collect more data in a better way? Yeah, obviously, it could have been. But considering that we got the requirements at around 11 or 12 on that first day, and we had all of the data flowing by 7 p.m., I think we did a pretty good job with things. So the first customer of this new real-time database was Epidemiology. We had infections to prevent and to trace. So now everyone was going to benefit from the data, but when I first arrived in incident command, there was the main room where people met, and then there was this smaller room off to the side. There was a bank of phones in the center, there were a couple of the infection preventionists around it, the IPs, and they were taking calls on everything between new patients coming in, PPE, what to do in various scenarios, and they were trying to record everything on a set of whiteboards that were tacked up along the walls. They needed a dashboard, and they needed it quickly. The first iteration of our dashboard, after we had data flowing at around 7 p.m., was ready by around 2:30 in the morning, and we presented it the next morning at the 8 a.m. IC meeting. They had their real-time data on patients available. Rebecca O'Donnell, the director of epidemiology, here, she needed to be able to focus on their primary goals: infection prevention, protecting and educating our staff, patient and employee tracking. They were spending hours tracking through medical records and pulling data from these different sources. The ability to instantly know in real time how many positive cases, how many PUIs there were, who was in-house, and their demographic information has always been a vision of theirs. We were all able to make that vision come to fruition. So knowing who the patients were and where they were in the hospital was just the first step of Epis Job. Their IPs had to trace every patient and staff member that came in, who they came in contact with, and then determine if there were any exposures, and then the next steps around there. This is why embedding analytics is so important. When I was watching them use the initial dashboard to gather this information, I then saw them recording the results of their contact tracing and exposure tracking into these separate databases or spreadsheets. They all had a slightly different process. They were going through all of this manual effort to record it, and then they would have to go through more effort to actually report that out. There was a basic missing piece in the center of it, one organized way of recording all of this. At the same time, our tent was receiving hundreds of patients looking for COVID tests. We had set up the tent as a triage and testing area in just a few days. It was fully connected to all of our registration systems and lab, and was set up to get a patient in, perform basic triage, take their sample, and then move them on either home or to the next level of care. In just over a week of full operation, we managed to test over 1,300 patients. Now, the one piece that was missing from this, though, was a way to notify patients of their results. Receiving a stack of 1,300 faxes of results from the lab just wasn't going to work. We needed a way to show the patient information right next to their results to be able to call them back and then record the results of those calls. This was another missing piece. So that brings me to, I think, one of the most simple but most important pieces of this entire pandemic response, which is really just simple data entry. We had this simple data entry tool that could take data from anywhere in our EDW, surface it, allow people to interact with it, and then record data of their own. We set it up initially with Epi as a work list. They could see all of the positive and PUI patients coming in, create a new record for them, record all of their contact tracing and exposure tracking information, and then save it and move on to the next. All of their IPs could record the same information in the same place. For all of the tent responses, we had med student volunteers and we had doctors that were all able to pull up the latest results, see the patient's contact information, be able to call the patient, and then notify them of their results within hours of the results coming back. The data being collected could then be surfaced in real time to incident command and leadership whenever they needed it. We had all of this data being collected into one or two consolidated places and then surfaced real time whenever we needed it. The people that needed information had it. All of this work brought us to the end of the first phase. We had a live view into all of the patients that were coming into Albany Medical Center. In-house, all of the positive, pending, negative PUIs, who was in an ICU, who was on a vent. We had Epi on a consistent process, logging all of their exposure tracking and infection tracing activities into one area. We had the tent callback application work, where everybody was able to notify the patients who had received the test of their results. All of this information was surfaced in the dashboards real time for incident command, leadership, and anyone involved in our pandemic response. So to show some examples, in the top left, we have our 7-day look back. This allowed us to see all of the patients coming in, whether they were transfers, whether they were a previous positive, whether they were tested in-house or externally for all of our total ins. We also had all of the total outs that were happening. Any transfers that returned to New York City, any discharges that we had, and unfortunately any deaths that occurred. This gave us our total out number, so we had the total in and out change for the past 7 days. In the top right, we had all of the different totals from Epi, how many exposures there were, what their contact tracing had found, all of the different information there. We had totals of all of our patients, who was in-house, who had been, how many encounters there were, who was positive, who was on a vent, how many had been vented and discharged, all of that information. On the side, to the right side, is a list of all of the different units we had and how many patients were in which status on those units. This gave everybody a real-time view into what was going on in-house. At the bottom, we had more Epi details, and then in the bottom left, we had all of the tent information. Who had been called back, who was still waiting, who we had attempted, got a wrong number, etc. All this data, as I said, was being able to surface in real time. So I worked really closely with Dr. Ashley Taleski from our medical director's office. She's also an attending in our ED. She was involved in almost all of the projects that we put together during our pandemic response, and she was being asked constant questions by everybody. So as she says here, before all of this started, we were well aware of some of our limitations. We had a hybrid paper medical record, limited real-time data, multiple disparate systems within our collective institution. We knew how powerful data analytics had become, and there was always a seat at the incident command table for the analytics team to be part of almost every decision and solution. This is what she believes was what allowed our hospital to succeed with each challenge this pandemic brought with it. So this brings us into phase 2, which is employee health. So once we had our heads wrapped around all of our patients in the hospital, we needed to tackle the next thing, which is keeping all of our employees safe. To do that, we need to start out with a very basic question that should be simple to answer. How many employees do we have? Where are they? What's their status? Now, all of this was a sort of daunting task because it seemed like regulations were changing every 2 seconds. Every agency, state, government, just anything remotely related to medical profession in general was coming up with their own rules, their own guidelines, and all of this kept changing on a moment's notice. We had these constantly changing guidelines that made taking care of people really, really difficult. We also were faced with shortages around PPE. Everybody wanted N95s, masks, gowns, and they were becoming harder and harder to get. All of the different systems that we have in the hospital, we're trying to upgrade. We're currently in the middle of a new HR system upgrade, but that's not coming until close to October. So our HR system runs on a mainframe, and it is siloed, and it barely talks to anything else. Employee Health Services, EHS, has their own system that also doesn't really talk to anything else. A lot of these systems, when they do talk to one another, that involves people recording things down on paper forms and then manually entering it in to the other systems. Now, at the same time PPE was becoming scarce, testing supplies were becoming scarce. The swabs and the reagents necessary to actually take tests of people, those were getting harder and harder to find, so we didn't have enough tests to just test all of our employees all the time. This was difficult for us, but then other testing sites started to pop up where our employees would then end up going to. If they got tested there, we would have no idea of what the results were, if they were positive or what. So we had another process that we had to manage. We had all of these different problems, and we needed a solution for them. So now that first step, just finding out who our employees are, where they are, and what their status is, seems like it should be really easy. Unfortunately, it's not that difficult, or it's not that easy. Now, we have around 9,800 employees on payroll. We have an additional 3,000 volunteers, contract staff, locums, etc., that work in the hospital. None of these are stored in the same system. So we have these different systems that each store different. We have one set of payroll systems. We have our EHS system that contains all of the people that are tested that go through EHS, which is almost everybody. We have a separate list of all of the people who have badges. We have an even separate list of all of the different positions we have in the hospital and which people are in those. Any one of these should have all of the people in it, but they don't. All of them don't match in some way or another. There's no link between these. So now I was relieved to hear that there was at least a link between our EHS and our lab system that happened automatically. I asked them, how is this communication occurring? Can we tap into it? How do we do that? And that's when I found out the answer was it happened by autofax. When EHS tested somebody, they took their specimen, they hand wrote their name and DOB on a piece of paper, they then mailed it to the lab then manually entered that into their lab system, and they automatically faxed the results back to EHS. This system just wasn't going to work. So here's the basic structure of what we set up. We joined all the different systems into one consolidated list of staff. We already had a feed from payroll. We tapped into the back end of our badge system and set up manual extracts from our EHS system. Unfortunately, that was the only way we could get data out of there. EHS had the largest list since they test everybody, but they were missing some from payroll and the other systems. There were no consistent IDs between them, so in many cases we had to use person matching algorithms using any fields that were available: name, date of birth, social security number. Fun fact, when I first started trying to do the matching, I thought that using last name and date of birth would be a good way of matching these things. Until I found out that we actually have 6 different sets of twins working at Albany Med, where last name and DOB is the exact same for both of them. So that obviously wasn't going to work, and this was a fairly difficult problem to solve. But we were able to get these people matching algorithms up and running. At the end of it, we had a full list of all of the people with all of the IDs from any system they existed in for everybody who worked for or at Albany Medical Center. Next, we took all of the EHS manual lab results and we ran the same person matching algorithms against those to make sure that anybody that had a test or any test that came out of EHS actually matched to an employee. Any of those that didn't popped up and were audited every single day. So all of this manual tracking back and forth, these person matching algorithms, they all have an error rate. So we set up constant daily audits of all of this. Anytime something didn't match up exactly, there were multiple matches, we had eyes on it and we held people accountable. The final list of this was a set of all of our employees and who is affected by this pandemic. The one piece that we were kind of missing though down there at the bottom right was any of the external tests. We also had to add in those. Anybody that notified us of an external test, we would record that manually to also get their information in. This led us to our final master list. Now, EHS was doing paper intake forms for anybody that came into EHS. We quickly switched that over to electronic. That piece of intake contained really valuable information for Epi. It contained where they were working, whether they worked with a mask, whether they worked with symptoms, if they received a quarantine letter from the state. All of that information was then linked up with their results and passed on to Epi so that they could do their contact tracing. Epi was able to use those exact same contact tracing applications we set up for patients for the employees, so it was the same process, all stored in the same place. Meanwhile, HR was able to look at all of this data and start everything that HR does when somebody needs to be out of work. They were able to start leaves, the backfill process, all of that information, and then record that into their own HR databases, which then we pulled in to join up with everything else. While that was going on, all of the results were then passed over to EHS, where we made another callback application. What this would do was this would surface the results of any patient or of any employee that needed to be called back, as well as pop them up a certain number of days later. The certain number of days later was to check to see if they were cleared to return to work, which of course, because of all the different changing regulations, that changed constantly. I think we started at 14 days, then it went down to 10, then it went to 7, then it went back up to 10. Everything was constantly changing, but our callback application could change and pivot with whatever we needed it to do. HR, risk, and incident command were able to see this entire process as it was happening so they could get live updates on all of this information. So this was another really successful phase of our project. I had embedded myself in with all of these different groups at all steps along the way. Anytime there was a manual process, anytime there was somebody recording some information somewhere, we analyzed it and we tried to think, could this be automated? Could this be captured electronically into some sort of discrete field? I was trying to teach them the analytics mindset at every step so we could improve this whole project. We never knew when the next state or government requirement would pop up. We would need to report on a different thing. We would need some other issue would pop up with our employees. We didn't know if an entire physicians group would just decide to strike, if a whole bunch of nurses would decide to not come in, if another one of our external testing sites would be shut down. All of those were the problems that we really needed to focus on. We couldn't be running around chasing paper forms and trying to do manual tallies of things. Rebecca O'Donnell from Epidemiology also worked very closely with this entire employee health process. And as she says, it was imperative that Incident Command know the state of the workforce on a daily basis to protect our staff. How many are on isolation? How many are symptomatic and being tested? When can they return back to work safely? The partnership between employee health services, risk management, and human resources was key in this pandemic as it related to keeping our workforce safe. All of this information was scattered and took days or weeks to collect. AMC needed this real time in order to make quick decisions in the moment. That is what we were all able to deliver. So now let's talk about how we brought all of this together. So the initial dashboard was stood up literally overnight and was constantly being adjusted and improved. The employee health work and data collection apps were all tested live. We didn't have time to go through the normal development cycle. This meant that while everything worked, there was obviously room for improvement. I'd been deeply embedded within Epi and all things employee health and started to notice a lot of potential areas for improvements. I was also in all of the incident command calls and heard other teams and groups with their own issues and realized other places that real-time data and analytics could help. So everything that we built was originally centered around tests. You were positive if you had a positive test. But COVID-19 was a sort of strange unknown disease, and people that we thought recovered were then coming back into the hospital. So what we needed was an entire readmissions algorithm to mark anybody that was tested in our hospital or in our EHS that returned to the hospital as still being positive. We also had that external testing process that I mentioned that was fairly manual. We were able to clean that up and actually build that into our EHR as an assessment so that we could start collecting that data in a more smooth, at the point of care method. Finally, we had this readmission algorithm set up, but we needed to be able to mark patients as being recovered or not. So Epidemiology had a special assessment built into our EHR that allowed them to mark patients as being recovered, so when they came back in later, they weren't marked as positive. Now we were able to track the entire progression of the disease from when they originally showed up until they were recovered. There was a completely separate initiative that focused solely on our first responders, split into two different pieces. First, anyone that was identified themselves as a first responder when they came in was pushed off into a different callback application where our pre-emergency medicine service would be able to, or our pre-hospital medicine service was able to perform the same contact tracing, infection tracking process that Epi was doing, but they were familiar with the companies, with partners, with leadership, so they were able to give it a more personal touch. This callback and tracing specific to those first responders made sure they knew just how important their relationship with our hospital was. The second piece of this initiative looked at all of the different companies that brought in positive patients. We were then able to notify them that yes, that patient that you brought in that was symptomatic was positive, to ensure that they used the proper PPE and that all proper precautions were taken. And if they weren't, they could then follow up with testing. Now, I worked very closely with Dr. Daly in the past, and he's chief of our pre-hospital medicine program. He was the one that came to me with this idea about taking care of our first responders. We're all really committed to our public safety partners, and having one initiative focused solely on them was really important to him, and I believe that we delivered. As he says, the tools built by the analytics team were of invaluable assistance to Albany Med's effort to keep our public safety partners and their families safe. By creating these organized dashboards that we could review each day, our team saved countless hours of merging and searching hospital records to track COVID exposures, as well as the test results of these at-risk law enforcement, EMS, and fire department personnel. Now, I called out just a few pieces of the work that we had done in those first few weeks of the epidemic, but here's some of the things that came next. We were able to move from these simple sort of flat dashboards to full interactive applications that were really able to deliver more value to incident command and leadership and anyone looking for that information. We were able to stand up the same callback applications that we use for tent testing and then EHS callback for pre-surgical testing. Once all of the surgical procedures were allowed, again, in our state, we had to have everybody tested within 2 days of that procedure. So setting up these callback applications allowed us to set up our drive-through and call back hundreds of people before their test with their results. We were also able to aggregate pieces of information from several different sources across the hospital to be able to identify congregate living patients. This is anybody coming from rehab facilities, from correctional facilities, any of those type of things where there's a lot of people together, because all of their incidence rates started to spike. Once all that started happening, if we had to dig around into all of these different systems to figure out if people were congregate living or not, it would have been a nightmare, especially once anybody going back to a congregate living facility needed a negative test before they did so. All of that would have been impossible without data. So next up, the serology tests started coming in. Antibody testing. We were able to bring all of that information into our dashboards to see who was positive and then who had a successive positive antibody test or a negative test, and be able to start understanding that relationship. Finally, we did a lot around N95 fit testing and use. We were able to track all of the employees that we had who were fit tested, what they were fit tested to, exactly which model and size, to be able to stay ahead of any potential shortages. We also were keeping track of who was using the different N95s to track increase in utilization and be able to notice areas where we could reduce that to try to stay ahead of any potential shortages there were. So now let's summarize. I've worked at Albany Med for just over 5 years, and we've talked about having real-time data the entire time, but we were never able to get it off the ground. It was always too difficult, or there was some other priority. During this pandemic, this became the only priority. We faced a huge crisis and did not let it go to waste, and were able to advance significant parts of our analytics and hospital performance overall in just a few months. We were never, thankfully, hit as hard as New York City or Westchester was, but we were so well prepared that we were actually able to take in transfers from the city. And our transfer center was able to coordinate transfers from the city into the other local hospital systems that were there. You can see here again our totals as of mid-July and see a graph of the overall disease's progression. The blue and yellow lines at the top show all of the admissions that we had in, and those yellows are the transfers that we took in from New York City. On the bottom, the green and black are all of the discharges and deaths that occurred. The purple line is what our hospital census was. We peaked at just over 80 patients. The purple dotted line extending past that red vertical line in the center was what our census would be if we were able to send congregate living patients back to their congregate living facilities once they were recovered. But we couldn't because they needed a negative test, and some people continued to test positive for weeks after they were here. This information was being able to displayed by our leadership during the daily video updates and for anybody that wanted a status of our overall hospital. As Rahm Emanuel says, the former mayor of Chicago, you never want to let a serious crisis go to waste. It's an opportunity to do the things that you didn't think you could do before. So what do I want you to learn from all of this? Firstly, incident command worked best with the least amount of barriers to communication. Real-time data, everyone available, clear lines of communication, transparency in all decisions. It's really amazing what you can get done when there's nothing that gets in your way. Real-time communication is key. Next, it's great when all the systems can talk to each other, when there are shared keys, when everything plays nice and all of the data is automatically audited, but that's not always the case. When there isn't that ability to automatically communicate, you need to have these manual processes. You need to audit those whenever possible and then hold people accountable for those audits. Automatic connections, when possible, audit everything that's manual. Being involved in incident command since the beginning helped immensely. Analytics is a group who specializes in joining data, breaking down silos, finding problems, and their corresponding solutions. The sooner that we can be involved, the better. But it's not just the analytics team. As I said, it's the mindset. Being able to recognize that jotting down some information on a spreadsheet hidden away on your computer is not the best way to do things. Standardized processes, discrete fields, being analytical in everything that you do, that's the analytics mindset. Have analytics from the beginning and at every step. Now, building a car while actively in the race isn't the best process, obviously, but it gets you moving. As soon as you can, though, you've got to try to start to identify the whole process and how it will function a week, a month, 6 months down the road. When we first started the real-time jobs with just a couple weeks of information, everything took around 20 to 30 seconds to process. But with every successive week, that kept creeping up and up. We needed to optimize, rethink, redesign, and improve. Nothing, especially that which is done overnight, is perfect. Always be improving. I've said it before, and I'll say it again. Collecting data at every step in the process in a place where it's easily accessible is key. I'm in analytics, so the more data, the better. Being able to have those discrete fields, the additional data elements, will allow you to more easily answer those questions that you never thought was coming. We kept getting more reporting requirements from the state, from the government, and all of that we were able to easily answer because we had the data. Collect data whenever possible. So that brings me to the end of my presentation. I hope you found this rewarding and were able to learn something as I took you through the process of my very first analytics emergency, the COVID pandemic. Again, my name is Michael Hauk. I'm a data scientist at Albany Medical Center, and I really hope you enjoyed this presentation. And I look forward to hearing all of your questions and providing some answers to you during the Q&A session after this. Thank you very much.